everybody. I appreciate it. My name is Mike Patterson. This is my first year getting a chance to work on the SCI Fair with some great people. I appreciate the opportunity. Today, we're speaking on a topic that was a big thing in my life right now, which is chronic pain. I've been in a wheelchair for about 20 years, and we have two great doctors that are working out the Kessler Foundation in West Orange, New Jersey. The first one is Jeanne Zanca, who's a PhD and an MPT, and is a senior research scientist in the spinal cord research over at the Kessler Foundation in West Orange, New Jersey. Her work usually focuses on secondary complications of spinal cord injury, with particular interests and strategies for improving quality of life among those with chronic pain and education of people with spinal cord injury and their caregivers. Our second doctor today is Dr. Trevor Dyson-Hudson, who's an MD and is the director of the Center for Spinal Cord Injury Research over at the Kessler Foundation in West Orange, New Jersey, and co-director of the Northern New Jersey Spinal Cord Injury System at Kessler, which is a spinal cord injury model system of care they're using over there. His researches include prevention and treatment and common secondary medical complications affecting people with spinal cord injuries. But finally, he also benefits from his own lived experience, as he has his own spinal cord injury that he had come to him in 1992. So these are two of our doctors presenting on pain today, and I hope they blow you out the water because they're great people.
Wow, that's hard to follow. Thanks so much. I appreciate that. Let's see. I'm just going to launch this.
Can't do anything.
Yeah,
Can you see that?
I can. And if you folks, can you hear me well? Just want to do a sound check.
Yes, can see
Yes.
hear and see you both.
Excellent.
Yes.
And then Trevor, if you have a second to hide the Zoom controls at the top, that would be great.
Sure.
So I will be starting us off today. So as you heard in the introduction, my name is Jeanne Zanca, and I am coming to you from the Kessler Foundation in West Orange, New Jersey. We can go ahead to the next slide. All right, so to give an overview of today's topics, first we're going to talk about what is pain. And I acknowledge that many of you are probably all too familiar with what pain is, but we're going to take a few minutes to talk about the actual definition of pain, because it reveals some interesting things when we think about different ways that we can tackle this challenging problem. We're also going to talk about some basic observations about pain in people with SCI. It's easy to focus on our own experiences, but we'll zoom out very briefly and look at it as a larger group. We'll talk about how to get to know your pain, and particularly different types of pain that people experience after spinal cord injury. We'll talk about different pain treatment options, strategies for working with your healthcare providers, and resources that we hope you'll find helpful. All right, so first, what is pain? So there exists an international association for the study of pain, and its definition of pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So I want to unpack this definition a little bit. The first piece is that this is an experience. So while there's often a physical cause, pain is by definition a psychological phenomenon, a phenomenon of the brain. Even when I stub my toe, I may have hurt my toe, but the thing that helps me understand that that's painful is my brain. And so the way I like to think about it is that everyone's pain is in their head. It's just what it is by definition. It's not a reason to dismiss it. It's just what pain is. Now, if we go to the next slide, the other important thing about pain is that it's a sensory and emotional experience. So it's got these two components. There's the sensation, the thing that you're feeling, the buzzing, the burning, the tapping, whatever it might be. And then there's kind of how it feels. It's distressing, it's annoying, it's terrible for some people. So there's a couple of layers to pain. There's sort of what's coming into our brain sensory-wise, and then how we appraise, judge, or think about that pain. And the next, also another important element of this, going to the next slide, is that it can resemble what you might feel if you had tissue damage, but you don't actually have to have a physical damage to something for pain to be real, as it's defined by the Association for the Study of Pain. Moving to the next slide. We wanted to highlight a little bit that acute and chronic pain are different. So acute pain is when you have a new injury, you strained a tendon, you pulled your back, something like that. And in acute or new pain, we see that the areas of the brain that are active are often the ones that are associated with sensations. There's a region at the top of the brain that is called the somatosensory cortex, and that kind of gets the inputs from your body about what's going on. Those are active in new pain. But when pain has stuck around for a while and it becomes chronic, we actually see a change in the regions of the brain that are more active. And in chronic pain, we see there's more activity in the sections of the brain that have to do with judgment and with emotion. So it's a different experience, which means we have to think about it and treat it differently than we would just a new injury. Moving to the next slide. What's also important to remember about pain is that it's not just about a physical problem. That's usually how it was viewed in the past. And while there's still some work to do in this area, there's a growing understanding that there are lots of different things that influence pain, including the severity of the injury or the illness that's underneath it, but also how we think and feel about the pain that we're experiencing. What fear, stress, and anxiety we have, either about the pain itself or about other things that are going on in life, the social support we have, and our prior experience, either our personal experience of pain or experiences that we've seen others in our family or in our circles have. And the good news about this is that there are so many factors, which means there's lots of things we can try to influence to make the experience of pain better and to try to improve the situation. So pain is very common. Probably don't have to tell that to many people in this room. We did a review a while back and looked at lots of different studies and had a pretty wide range, depending on who they looked at, all the way down from 26%, which is still pretty significant, that's a quarter of people, up to 96% of people asked, do you have pain? And the answer was yes. Now, interestingly, pain prevalence, so how many people in a sample have that pain, is not really associated with gender, level of injury, or completeness. Everybody's at risk for this. It's a challenge for everybody. And that's true of traumatic and non-traumatic SCI as well. And there's a large number of people that report really disabling pain, up to about a third of people who are experiencing it. It affects sleep, it affects work, lots of activities of daily living. And it's a really important factor that decreases quality of life above and beyond the primary impairments that spinal cord injury creates in sensation and movement. And if you hit one more down arrow, Trevor, for the last point, it's a highly complex phenomenon. People with spinal cord injury have lots of different kinds of pains simultaneously. So most of the times in medicine, when we're talking about a condition that's painful, we focus on this one condition that's creating one kind of pain. But with spinal cord injury, you have the underlying spinal cord injury itself, and then a whole bunch of different things all going on at the same time. So I'm going to pause there and transition to Trevor, who's going to speak more about the different types of pain that people with SCI experience.
Great. Thanks so much, Jeanne. So, as Mike was saying, full disclosure, I have a spinal cord injury myself. I'm C6, C7, quadriplegic, complete. And, aside, at the time of my injury, aside from the obvious paralysis and the loss of sensation, one of the things that I noticed right off was a burning pain. And it just was, it was almost as distressing as the paralysis because it was just there all the time. And so I have my own experiences with pain. And one of the things that I found, over time was, trying to get to know the different types of pains that you have. Because if you understand what the different types of pains are, then you can either come to terms with how you can address each one or find treatments that work most effectively. Now, usually clinicians, especially pain physicians or clinicians, look at pain in different ways, right? Or different types of pain. We try to break it down because, as Jeanne said, people with spinal cord injury, it's very complicated. You can't just use one scale, like what's your pain today, 0 to 10, because a lot of times people with pain have multiple pains occurring at the same time. So their nerve pain could be, really low today, but their shoulder pain could be really high, or vice versa. So what we try to do is break pain down into different types. And the way to think of it, and this, as I said, is a very busy slide, but in your minds, you want to think of it as two broad categories. Nociceptive pain, and I'm going to go into these in greater detail. One is nociceptive pain, and that's kind of the pain that you're familiar with. If you poke somebody, it hurts. That's nociceptive pain. And then there's neuropathic pain, and that's the nerve pain. So let's explore those a little farther. So nociceptive pain arises when you activate a nerve fiber, and that nerve fiber carries pain signals to your brain telling you that it hurts, right? It's like if you are something poking you, it tells you to move. Now, generally, we break this down into either musculoskeletal pain, and that could be arthritis, fractures, inflamed tendons. So that's the shoulder pain. And usually that's a dull, aching, usually related to movement, position. It's tender on touch if you put pressure on it. There's visceral pain. Visceral pain can be kind of tough to diagnose because you get this kind of vague, cramping, dull pain. It usually can be associated with things like constipation in people with spinal cord injury. Sometimes people who get urinary tract infections, especially if you have some intact sensation. Appendicitis can be very challenging to diagnose in people with spinal cord injury. So we sometimes look at kind of subtle symptoms. So, as I said, there's that kind of cramping, dull, tender pain that you have. It's usually in the internal organs, and it's related to some of their functions. So it may be related to eating, or when you're trying to have a bowel movement. You may have dysreflexia. There may be some associated symptoms, and you just don't feel right. Other types of nociceptive pain could be just a dysreflexic headache in its own, pain from a pressure ulcer if you have sensation, and migraine pain. Nerve pain is the big one for a lot of people, and that one's a tough one. So this is usually caused by, as it sounds, pain to something affecting your nervous system. And usually what you will have is either, this can happen in areas where you have no sensation, which is kind of baffling because people will say, well, how can you have pain in an area where you don't feel? But you absolutely can. So don't let anybody tell you that you can't. You may also have, in certain areas, if you have preserved sensation, a very hypersensitive, almost painful touch in that area. And nerve pain often is that kind of burning, tingling, pins and needles, electric pain. It's kind of, for an able-bodied person, I try to tell them it's like a really bad sunburn, or if you fell asleep on your arm, that kind of weird tingling that you get. And that's actually an example of nerve pain. And the way we approach nerve pain is either whether it's pain right at the level of your injury, and so that's an at-level pain, and it's usually a band within 3 levels of your injury. And that's from irritation of either the spinal cord or the spinal roots. Or you can have what's called below-level pain. So you have pain, let's say, down in your toes or your buttocks or somewhere far away from the level of your injury. So if I use myself as an example, my level's C6, C7, so my sensation stops being normal around my chest. However, I feel like I have burning in my toes, actually pretty much burning everywhere below the level of my injury, but especially in my feet and my thighs. So, all these different pains themselves have unique pain management options. Now, it's important to know that any successful pain management requires a combination of approaches that will address multiple targets. There really is rarely is there one single thing. If you're lucky, there may be, but in more complicated cases, you're going to need to do kind of a combination of things. And that's what we're going to cover today. And each person's pain is unique, as Jeanne was saying. So we need to customize this to the individual, whatever their needs and their priorities are. Because you don't want pain dictating your life. The important thing is to kind of take control. I know it can be consuming and it can be very frustrating, but for people with spinal cord injury, it's so important that you get back on with your life or have your life. So let's talk about neuropathic pain treatments, okay? I'm just going to go over these briefly. There's medications, there's drugs. So pregabalin is the one that is actually approved for treatment of neuropathic pain. So that's also known as Lyrica. But gabapentin is another one or Neurontin. Gabapentin, Neurontin are the same thing. So those are, and amitriptyline, those are the kind of three main drugs that we use for managing pain. If those don't work, some second line treatments are tramadol, but that's generally a short-term treatment. And then there's some other medications. Third line therapy, so, some additional treatments that may be effective include cortical transcranial direct current stimulation, visual combined with visual illusion. So these are a little more experimental treatments. Now, one of the things you'll notice, and we're going to touch on this later on in the presentation, is that oxycodone or opioids don't come in till fourth line therapy. So there's this real movement, and many of you may have experienced this already. There's this movement in people who treat spinal cord injury and in general away from opioid medications. But as I said, I'm going to address this later on in our presentation, because I think there may be some of you who have questions about this. And then finally, there's some surgical options, which again, I'm going to go in later if we have time. So let's talk about the musculoskeletal pain treatments, okay? So really what we're trying to do with those is we're trying to either address the pain, so the acute or the chronic pain. Now, we can do that through rest. However, for people with spinal cord injury, that's not always possible. And when I'm talking about musculoskeletal pain, in this instance, I'm talking about the upper limb pain. So, somebody who uses a manual wheelchair, who gets shoulder pain, elbow pain, or wrist pain, or the person who's sitting in a power chair, reaching, just sitting there or typing every day. Or if you're not using your arms as much, you can start to just have pain from lack of use. So you can get pain from any number of ways, and it can be musculoskeletal, so it can affect people of all levels. So obviously, if it's overuse, then trying to rest, but that's not always practical because people with spinal cord injury rely on their upper limbs for their mobility and doing things. You can take medications, so ibuprofen, acetaminophen, Tylenol, and tramadol. So it's trying to kind of get at either the inflammation that's there or just address the pain. You can do a steroid injection into the joint or, into the wrist for carpal tunnel. The downside of steroid injections is that they can be damaging to the tissue. Other things you can do are ice and heat. Some people find that useful. Acupuncture, I've done some research in the area of acupuncture, and I've found that to be effective for people who have kind of that, muscle ache in the back, muscle tightness, trigger points, tender points, myofascial pain kind of thing. So that's treating the pain. One of the things you want to try to do also is address any disabilities created by the pain. So because of pain, you may have trouble transferring. So you want to consider adding a sliding board. I'm going to go into that in a little more detail. Exercises, it's important to do exercising. And again, I'm going to go into that in a little more detail. Ultimately, prevention is best. And it's never too late to take some preventative measures. And I'm going to go into these in a little greater detail in the next few slides. But there's a great resource out there for people. If you haven't seen this, it's produced by Paralyzed Veterans of America, and it's preservation of upper limb function in people with spinal cord injury, and it's what you should know. And they have a clinical, they have one for clinicians And then they have one for people with or consumers with spinal cord injury. And so, you know, two different versions, and they're a great resource. So I highly recommend you check them out at the PVA website. I have started to explore some of these cell-based regenerative therapies. So my research, that's one area of research I'm looking at. So I'm looking at some different cell-based. I won't use the term stem cells because I'm not quite sure they're stem cells, but this is using your own body's tissue cells within your body and trying to harness your body's own ability to heal itself. Ultimately, you really want to try to avoid surgery if possible for shoulder pain or wrist pain. And the reason is because you rely on your upper limbs. So having surgery can have negative consequences. It means you can't use that arm or that wrist for a while. And that makes you that much more dependent. I think people don't realize how devastating that can be until after the surgery. And so you really want to do everything you can before pain gets bad and you have to get surgery. So what are some things? Well, if you use a manual wheelchair, ideally you should be using a wheelchair that's as light as possible and is adjustable or fits you, because that allows you to adjust it to your body to set it up so that it's as easy to push as possible. Because if you're using a manual wheelchair, you're using your arms day in and day out, and that can put you at risk for overuse. You want to make sure that the wheel is positioned properly. So what you'll see on the figure on your right, that the person's arm is at about 100 to 120 degrees. And that is good placement because it gives them good access to the push rim. So they get nice, smooth push strokes. If their hands are too far from the push rim, they don't get as good a contact on the push rim. Now, if you're having shoulder pain or you're just very active and you're a manual wheelchair user, there are power add-on devices that you can use. You know, I mean, another option is if your shoulder pain's really bad is switching to a power wheelchair. But for some, they don't like that idea, you know, me included, because, you know, with a power wheelchair, you have to have a van. It's difficult to transport. You feel a little less independent. So for those who have manual chairs, an option are these power add-on devices. And one is called the eMotion wheels, which is the wheelchair on your left. And those are actually wheels that those wheels have batteries and a motor. And by pushing the push rim, it activates the motor. There may be some of you out there in the audience who have these types of wheels. And these are great. I mean, they give you a great boost when you push around. And we found that people with higher level injuries at Kessler in the hospital, this is a good way for somebody with a higher level injury to be able to use a manual wheelchair independently, because it gives them a nice assist. An alternative is something called the Smart Drive. And the Smart Drive is just clips on the back of your wheelchair and is synced with a Bluetooth watch. And by tapping the push rim, it kicks in a motor that then drives you along. And then if you double tap again on your push rim, it turns it off. And so that I have a Smart Drive. I actually have both of these devices, but I really like my Smart Drive. The downside of the eMotion wheels is that they're heavy. So if you're loading it in and out of a car, they're like 35 or 40 pounds on your wheelchair. Whereas the Smart Drive, it's a device you just snap on the back like they have there, and it only weighs about 8 or 9 pounds. So if you're a manual wheelchair user, one of the other things you can do is optimize your propulsion or stroke pattern, we like to say. So I don't know, can everybody see this video? So you'll see this image on the left. This person's kind of doing a very choppy wheelchair propulsion. Whereas if you look at this person on the right, they're kind of doing this nice smooth stroke, right? So if you consult the diagram over here, you want this kind of circular pattern, or this kind of looped pattern. This is the kind of pattern I use, and this is the one in the image. You really don't want that kind of choppy push pattern. So that's one thing you can do. So another thing you can do is try to optimize your transfers. So now this can apply to people both in manual chairs and power chairs. Ideally, you want to kind of transfer at an even level, right? So this picture, some of you who have manual wheelchairs may drive trucks or SUVs, and that's hard on your shoulder. So just be careful, because if you do it improperly, that you might risk injuring your shoulder. And really what you want to do is just make sure your chair is angled at kind of 30 or 45 degrees to the surface. Make sure you get your feet out from the footrest and then transfer up. And again, ideally a level transfer. If you have a power chair that has can raise or lower, then raise and lower your power chair to about the height of the surface you're transferring to. Use a transfer board. I've started using a transfer board more, and I'm glad, because it just makes my transfers that much easier and makes it easier on my shoulder pain. Another trick is to transfer towards the painful side, because the shoulder that you push off with is generating the most force. So you know, if you have a painful shoulder, you want to transfer with the other shoulder pushing. So just something to think about. And again, I use a sliding board. Exercises are important too. You want to stretch your chest muscles, so the chest and the front, your biceps. And then you want to strengthen your back muscles, because when we're in a wheelchair, we're kind of sitting slumped forward. So our chest muscles and the front of our shoulders and our biceps get tight because we're hunched forward, and our back muscles get overstretched. So if by stretching the chest muscles, you kind of open things up, and then by strengthening the back muscles, you kind of pull things back. And that's just kind of simplifying everything. Now, treatments for multiple pain types. So let's spend a little time talking about opioids, and I'm happy to answer questions at the end. But as you probably know, use and treatment of people with spinal cord injury pain is controversial. I mean, this is a hot topic in the news today, not with spinal cord injury in particular, but just in people in general. And as a result, you know, people with spinal cord injury are affected by that. There's a lot of concerns about the side effects, concerns about misuse and abuse. For people with spinal cord injury, I mean, the downside is they can be very constipating. They can depress breathing. People with spinal cord injury are at risk for sleep apnea. That's that when you're sleeping at night, your breathing stops, and that can be life-threatening. They can also sedate you. They can impair your thinking. So they have negative, side effects. However, there are times when they are appropriate for people with spinal cord injury. So just like for people with cancer, there are times when people with spinal cord injury, it's appropriate for them to be on opioids. Certainly they're used for people who have acute injury or illness. So if you had surgery or something, you may receive 1 or 2 weeks of an opioid. For those people who have severe chronic pain, and usually we call chronic pain anything greater than 3 months, opioids may be the only thing that may be effective in them if all other treatments have failed. So really, it's worth trying. And this is a discussion you have to have with your doctor. There may be instances when it's appropriate. Now, I just want to make you aware there's a fact sheet Opioids and Your Health. That's available on the Model Systems Knowledge Translation Center's website. The link is there. Anybody who uses opioids or was on opioids and is having difficulty, I urge you to download that and then perhaps have a discussion with your doctor. But I mean, one of the things, you have to make sure that the benefits outweigh any risk. I think that's the important thing, and really monitor use closely. But, in some instances, they can be effective for people with spinal cord injury. So, is this all we have? Is this as good as it gets? So, what are some of the other treatments that we can do? What other options are there for people with spinal cord injury to address their pain? And I think my colleague Jeanne Zanca is going to take it from here.
Yep, absolutely. So many of the treatments that we've been talking about so far have to do with things that you can change from a physical standpoint, or medicines that act in a chemical way on the brain and the body. And an area of growing interest is what are called mind-body intervention approaches. Now, there's not really a clear definition of what mind-body means, but these are interventions that really focus on the emotional and thinking aspects of the pain experience. So remember before we talked about how there's a sensory part, the sort of the signals that are coming in about something being wrong with the tissue or seeming like it's wrong. And then there's the thoughts and feelings, the fact that it's distressing or unpleasant or a problem. And so these interventions usually involve conscious awareness of thoughts and feelings and sensations. They're applicable to all pain types, and they can be readily combined with other treatments. So moving ahead, there are several different ones that I'm going to highlight, and there are a few more that aren't represented here, but I've tried to pick the ones that I think are the most accessible. You had the privilege of going through a yoga session before this, so I'll say very little here because you've had that experience already, other than to highlight a couple of additional online resources that you might find useful in seeing videos and being able to participate in classes. For relaxation techniques, there's many techniques that involve breathing. There's a technique called progressive muscle relaxation where you do breathing along with contracting of the muscles that you're able to contract. There's guided imagery in which you might imagine yourself in a place of comfort or another place that helps to relax you. There's lots of videos on YouTube, and a web search will find lots of different things that can take you through these guided techniques. There's also cognitive behavioral therapy. Now, most of the time, this doesn't get put in the same box as mind-body interventions, which tend to be a little more holistic, a little less conventional. CBT has been around there for a really long time. And that triangle that you see there, the points on that triangle are thoughts, feelings, and emotions. The idea is that these things all interact with each other and affect our well-being, how we feel. And so CBT, or cognitive behavioral therapy, is designed to help change patterns of thinking or behavior in ways that increase your well-being. These sessions can happen in groups or one-on-one, and they usually involve a psychologist. Moving on to the next slide, there's also meditation and mindfulness, and these kind of interact. Now, meditation isn't any one thing. There's lots of different forms of meditation, and they don't necessarily involve sitting in the lotus position by a lake and looking into the clear blue sky. There's lots of ways to meditate. The main idea is that they typically involve a quiet location, a specific posture of some kind, and that can be seated in your wheelchair, a focus of attention, often the breath, sometimes a word or a phrase or a sound, and a non-judgmental attitude, meaning that these techniques help you sort of live in the moment without layering judgment on what's being experienced. And this really comes into play with this mindfulness idea. So mindfulness is something that's gotten more attention in recent years. It is defined as non-judgmental moment-to-moment awareness. So if you look at the picture, and I acknowledge that it's small, there's a little stick figure there of a parent and a child, and the bubble over the parent on the left-hand side is just full of stuff. What I had to do yesterday, what I have to do tomorrow, the things I don't want to do next week, all that stuff. Whereas the child is just looking at the scene. They see the flowers and the weather and the blue sky, and they're just focused on those things. So mindfulness is about kind of breaking us out of this pattern that many of us have of thinking about and worrying about lots of other things, just focusing on where you are in the present moment, and in a way that's sort of detached so that you can think about the experience that you're having and separate that from the emotions and the judgments that come with it. So in the case of pain, that would be practicing the ability to live in a moment with a painful sensation, but sort of separate out the distressing aspects of it. And the goal of it's really to reduce suffering by practicing the ability to kind of separate these. So if we go to the next slide, there's lots of different ways to connect with these programs. And many of the treatments we've talked about before involve a therapist or a physician, but many of these don't. So you can use community-based programs, the YMCA, senior centers, Parks and Rec, lots of small businesses in various towns have individuals that are skilled in teaching these different techniques. If we go on to the next slide, there's also lots of web-based resources. And I've just linked a few here. There's a first site there that says it's preparing for your surgery. It was designed for people that are going to have a surgery to kind of give them stress management and relaxation techniques going in. But the recordings that are there are still useful in other cases. So I've included that there. There's also the American Chronic Pain Association, which is a consumer-oriented association, meaning it's oriented towards people with pain rather than healthcare providers. And they have a number of different audio recordings that you can listen to help take you through some relaxation exercises. There's also a great center at UCLA that's focusing on mindfulness, and they have a page with lots of different recordings of different exercises that you can do in both English and Spanish. So I've linked that here as well. For those therapies that might involve the actions of a psychologist, like cognitive behavioral therapy, and many of the other mind-body therapies are used by psychologists, you can use the American Psychological Association's website to help find a professional near you. And it's a pretty good database that lets you search by specialty areas. So you can look for people interested in pain, people interested in disability, and see what you can find. I know our experience at our rehab center is that we have a small number of psychologists but a large number of people trying to seek their services. So you may find that if you go outside the typical rehab realm, you may have an easier time connecting with a very helpful therapist who can provide some input to you. And then if we go to the next one, we're going to transition here to Trevor, who'll talk a little bit about marijuana and the role that can play.
Sure. So this is another topic that is really gaining a lot of news over the last few years. As many of you know, the marijuana or cannabis plant contains THC and CBD, and it activates receptors in the central nervous system. One of the things I think that it does is it alters how you perceive the pain, how the brain perceives the pain. So as I think Jeanne was kind of alluding to with the mind-body thing, it's pain stops being distressful and it's just a sensation. So marijuana or cannabis may serve that role so that you feel it, but it just stops being as distressing. There's also noted benefits from not only decreased pain, but I've heard people report decreased spasticity. And there are some research studies out there, at least small studies, showing that that vaporized cannabis or different types of extracts can relieve pain in people with spinal cord injury. There are also some in spasticity. There's unfortunately very little research in this area. So, I mean, it's really kind of something, some of you may already be pursuing this. This is an instance where I think people with spinal cord injury are probably leading it more than researchers in the area of spinal cord injury, because people are having their own experiences and finding what works for them. I think it's important to discuss it with your doctor. As I understand it now with New York, I'm a New Yorker, I'm from upstate, but recently New York has legalized marijuana. So don't quote me on what the laws are, but it's something you can pursue. But for those who are interested in pursuing more, certainly have discussions with your doctor or a doctor. Different doctors have different attitudes about marijuana or its derivatives. The other thing is that, there are potentially side effects. So it's trying to find a formula that works for you, because there can be cognitive issues. There can be other things that can sedate you, make you feel tired. It can impair your judgment. So it's kind of a trade-off, like, with many things. So, okay. Surgery. So I just want to touch briefly on surgery. This is often a treatment of last resort, as I said, with the upper limb pain. I'm really just going to touch on it briefly, but there are pumps, that deliver small amounts of pain medications. There's stimulators, there's spinal stimulators. Some people find these effective, some people don't, unfortunately. There is something called a rhizotomy or a DRES procedure, which is just dorsal root entry zone ablation, or basically destroying the nerve, because the dorsal root is where pain sensation or sensation comes in. So the idea behind it is that you're just trying to eliminate the nerve that brings sensation to the spine. But again, this is a treatment of last resort because you're basically destroying the nerve.
All right, so in this next section, we'll talk a little bit about working with healthcare providers in a productive way. So the first thing is that it's really important to know your pain. The hard thing about pain is that it's not something that we can easily see as healthcare providers to figure out what's going on. So we're really reliant on what the person experiencing pain is telling us about their pain. So you may find it helpful to use a journal or a log to document your pains. And I do say pains plural here because you're going to have more than one, and you can think about what those different experiences are. So things to note would be the character, how it feels, what its intensity is, that 0 to 10 rating you're always getting asked for, the timing of it. So what time of day does it come on? What time is it better or worse? How it's affecting your functioning, like your transfers, other activities, and other circumstances surrounding the pain, like how much sleep you got the night before, or whether there's something stressful going on. Look at your log to identify patterns, and then note what you observed for each of your pains. Kind of summarize those things, because those will be useful to explain to your healthcare provider as you go through. So for the next slide, the next step really is to identify your goals. So it's very natural that reducing pain intensity, getting that 0 to 10 rating down and just not having the pain anymore would be a primary goal. But as we talked about, there's lots of different aspects of pain, and sometimes reducing that intensity is not always as feasible as we would like. So think about other goals too that you might want to reach. Having fewer episodes of pain if your pain comes on in different spurts of attack. Other goals include improving your function. Maybe mobility is getting really hard on your shoulders using manual. So you might want to use some of the power add-ons that Trevor was discussing. Or maybe there will come a point where transition to power makes more sense to get where you want to go. Improving sleep quality is really important. There's a cycle between sleep and pain. Pain is sleep, and less sleep gives you more pain. So there are lots of things that can be done, like something we've referred to as sleep hygiene, making sure you have a routine, a set time every day you try to go to bed, not doing something too stimulating right before you go to bed. There are and medications too. So there are things that can be done to address sleep, which may have some other effects on pain. Other goals can include things like managing stress, both to reduce your pain potentially, but also to help you manage the stress that the pain itself creates. And then still other goals can include improving your mood, and then also others, if you go down one more, Trevor, returning to enjoyable or fulfilling activities despite your pain. No, you're all good. And that's important for bringing distraction. Sometimes distraction is a useful strategy for dealing with pain, and also just to try to enhance your quality of life in lots of ways. Even if other treatments are not really succeeding in getting that pain and density down, there are other ways to enhance that quality of life if you look at the big picture. So after you've identified your goals, the next thing is to schedule a visit. Now, not every treatment that we've talked about, in fact, many that we've talked about today, needs consultation from a healthcare provider, but many of them certainly do. So it would be important to think about the kind of provider that you want to see. Usually a PCP is where you need to start, especially if you're going to need referrals, but you might see your SCI doc, a pain specialist, a PT or an OT or a psychologist. And ask ahead of time if you are really having a problem and you want to be able to get more time with your doc to be able to talk about it. Ask if you can get a longer appointment. If you just come in on a regular day and go through a whole long story without them realizing it, they might not be able to accommodate you. But if you ask ahead of time, it's possible that they might extend that. You never know what to ask. The next step after you've scheduled that visit is to get ready for it. So think about what your specific goal is for that visit. And there may be more than one, but are you looking for a referral to another specialist? Do you want a prescription medication? Are you needing imaging because you want to find out what's going on with your shoulder, for example? So think about what you want to accomplish with that visit. And then prepare the background information that you're going to need to share with your physician or other clinician to help accomplish that. A list of your meds or other treatments, summary of your pain log, past treatments and what the results have been. If you can type that up and share it in some way, that will make life a lot easier and save you a lot of talking, because they'll have something they can review and put into your medical record. Make a list of the questions you have and the points you want to discuss, and consider taking a support person with you if you want another pair of ears to take in what's going on. So once you're prepared for that visit, during that visit, take notes. Do not rely on your memory. People have very good memories about some things, but often less so than they think. So use your support person if that's helpful. Ask if you can record the discussion. Many docs will be willing to do that. And take pictures. You know, let's say your doc kind of draws you a diagram about what's going on with your shoulder. Snap a picture of that so you have it. If you get recommendations from your healthcare provider about something, share your thoughts about them. If you have reservations or you feel you need time to think about them, let them know that. This way, if you end up not following that recommendation, it doesn't look like you're being difficult, just trying to think about it and go about it in a careful and deliberate way. And then you should think about what the next steps are going to be. So is that getting a referral documentation or a prescription form? And when should you come back and see this provider again to check in on your status? And then finally, after you've had your visit, there's some follow-up. So follow through on the things that you and your healthcare provider agreed upon together. So I'm not saying you have to do everything your provider recommends. You should work on that together and have that be a consensus decision. If you got a test of some kind, keep copies for yourself. Make sure they got to your provider before you have your follow-up visit, so they have all the information they need to speak with you. If you got a new treatment or started a new treatment, document how that's going. Is it helping and how? And make sure you make that follow-up appointment and keep it so you can keep the communication going. So finally, I'm going to very briefly highlight some resources. Trevor had mentioned the Model Systems Knowledge Translation Center before. They have a special set of resources on pain and spinal cord injury, which is linked here. And then if you go to the next slide, there's also a lot of different topics that are addressed, and some of them have a very close connection to pain. There's the opioids fact sheet that Trevor mentioned. There's some resources on setting up your wheelchair and maintaining a wheelchair, good transfer techniques, spasticity. There's lots of great information. So check out msktc.org, and there's lots of things. Next, I will send you to the Christopher and Dana Reeve Foundation. Many of you know well, and we're grateful to them for helping make today's event possible. They have a booklet on pain management that's available, and I've linked there a pain page. And you can find it if you just go to the main site, go with Living with Paralysis, and then there's a secondary complications section, and it will take you to this area. Another great source of information is provided by our colleagues at the University of Pittsburgh. And there's two resources from them I'm going to share briefly. One of them is an online web-based transfer training program. So this can help you optimize your transfer technique. It gives you specific suggestions for how to perform your transfers in a way that'll help reduce the stress on your joints and either make your pain less bad if you have pain right now and you just are trying to reduce the stresses on those already painful joints, or prevent pain in the future. And they also have an online course for maintaining a wheelchair, which is really important. If it's not functioning correctly, then that's going to add stress in lots of different ways. And so that's a useful program as well. Next, I'll point out the American Chronic Pain Association. So this is an organization focused on people with pain rather than healthcare providers, but it provides good information for other clinicians as well. And they've got some really great tools. If you go to the website and you kind of look in the middle of the top black bar, there will be a link about pain management tools. They've got some templates for logs. They have an app so that you can search in the Apple Store or in the Google Play Store to help you track your pain. So there's lots of tools out there that exist that you can use. They're a really great resource. And finally, just as general great sources of information, there's the Paralyzed Veterans of America and United Spinal Association as well. So with that, I think we are finished and we're ready to take questions. I know there were a few things in the chat that we can address, and however you'd like us to do that. All right, so I'm going to look at some questions.
Well, after you do that, I definitely
yeah.
have some questions. No, you go ahead and do the chat first, Dr. Zanca, but I definitely had a question for you guys.
Sure. So I'm going to ask my colleague Trevor, would you mind fielding the last question about marijuana and the blood-brain barrier to the extent that you know?
Yes, to the extent I know, it does.
Okay.
It does. So the question somebody had was, does marijuana cross the blood-brain barrier like opioids do? And the answer would be yes. And I mean, not speaking from personal experience, well, maybe, but it can alter your cognition. So things that alter cognition are crossing the blood-brain barrier, like alcohol and other things like that, opioids, and affecting the brain. But a great question.
Thanks, Trevor. And then I see there was also a question about the wheels that we mentioned, and I think we'll probably, the best way to do that is probably get some information to Chris to send out. But is there anything you wanted to add about that, Trevor?
So let's see. Sure. So especially about the manual wheelchairs. Okay, emotion wheels.
Emotion.
Yeah, sure. So I think if actually if you have access to the internet, well, obviously you do, if you're here, do a Google search for emotion wheels or emotion manual wheelchair wheels. And, but certainly we can send you a link to those different things, but, they're great because, they're what are called push rim activated power assist wheels. And, as I said, there's a battery in the middle and there's motors there. And by just pushing the metal, so they have metal push rims, but for people with impaired hand function, they also have kind of a snap-on grippy rubber adapting thing. So that way, the metal doesn't slip through your fingers. And simply by just giving it, you can adjust them too. So you can, and if you have side-to-side differences, so let's say you're stronger on one side than the other, you can adjust each wheel. So one, and really what it is it just takes a certain amount of force and then it gives you a boost, a defined boost. And you can adjust all those things. And that's different than the Smart Drive, because the Smart Drive clips on the back and that just ramps up in speed. So that's less responsive. The benefit of the Smart Drive is it just clips on and off rather easily, whereas the emotion wheels are heavy. But they're great for people who travel, just who have impaired upper limbs or have pain, and want to move independently in a manual chair.
Yep, and while Trevor was giving that explanation, I threw some links into the chat.
Oh, wow, thank you.
The top one is for emotion. So I just did what Trevor said and Googled emotions, but there it is. And then the second link is for the Smart Drive device. So if you want to check them out now, you can grab those links and bookmark those pages.
I just had a question for you guys. First of all, I wanted to thank Dr. Zanca and Dr. Hudson. That was like a wealth of knowledge as far as pain management is concerned, and I needed to hear every word of it. So I appreciate you guys for that. I guess both of you could answer it, but it was kind of brought up when Dr. Hudson was talking about it. You were talking about that dorsal root operation, which is considered like a last resort operation. And I'm a T7 who suffered a gunshot wound 20 years ago. And I'm personally at this point where in about the next 2 weeks, I'm going to get this operation. And with the bullet being lodged in my spine, I don't think my percentages of ever walking again were that high anyway. So now I'm going to get this operation. And, when people hear last resort of anything,
oh, right. No,
you think it's bad. But is my goal more just I need to relieve my pain to have a better quality of life than looking at it as, okay, this is the last resort and I just need to go through pain and not do it because I don't want to face the last resort.
Right,
so
right.
I'm just trying to make sense of that.
Sure. No. So that's an excellent question. So they're not, so dorsal root procedures, different functions enter the spinal cord at different points. So sensation comes in through the back, the dorsal part, whereas motor comes in the front. So what they're trying to do is get that sensory part and get that nerve. They're not severing your spinal cord. They're not going to do the fibers that bring in the motor function or some of the other functions. They're really trying to target the sensory area. The reason why it's kind of a treatment of last resort is surgery should be a treatment of last resort. And so, if things, it's a risk benefit. And medications can have their side effects too, right? They can be constipating, they can make you feel certain ways.
Definitely.
And so you're just trying to find something that works for you. And I've spoken to, I don't know it. I don't do it. It's not a procedure I perform, so I can't speak to it. But I certainly, when I talk with other doctors, I always have several who come up to me and say, you know, I do this or whatever. I'm glad you talk about it because I find it effective in certain people. So, and it's tough because again, it's controversial because there are people who say absolutely don't do it.
Right.
But there are just as many physicians who say this can work for some people. So.
Okay. Well,
So I
thank you
hope that
very much.
helps, Mike. I hope
Yeah.
that alleviates some of your concerns.
That definitely clarified things, and it kind of eased me down now. I understand that they're not taking my motor sensories. They're just trying to help with the pain, which makes me feel a world of better. So thank you.
Yeah. Yeah, it would just be the sensation. So if you have some like sensation in that area, you might be then numb, like you wouldn't have it anymore. But it shouldn't, like, whatever potential motor you do have, shouldn't be affected.
This is Dr. Jeanne Nichols, and I've got a question about marijuana and combining it with oxycodone, and also what happens when patients and the doctor's ideas about pain control are like a mile apart.
Oh boy, that's a tough one. And you have a lot more experience with that, I'm sure. That's whenever you combine things. I mean, I think that's a dangerous situation. You run the risk of more side effects. I don't know what to say in terms of when doctor and patient just can't come to an agreement. I mean, I think that's a challenging. I guess I would flip. Do you have some experiences of your own, some techniques that you use that may help?
Yeah, sometimes I try to just validate and say, I understand that your goal is having zero pain for the rest of your life, but truly medicine is not at that point yet, and I don't think we can get there. I think we could get to a goal of a pain score of 4 or 5. How about we work toward that? Sometimes that's acceptable, sometimes that's not.
No, I think and I'm glad you brought that up, because I will say, I mean, certainly from my personal experiences, and I don't pretend to speak for everyone with a spinal cord injury or don't want to, I think I've come to accept that I'm not going to get a pain of 0. I think when I was first injured, that's what I was hoping for. Because pain was a new experience, that kind of burning pain, and it just drove me crazy. But then at a point I realized it was a sensation, and there are certain things that I'm more aware of my pain, other days that I'm more aware of my pain than others. And, Jeanne brought some of these up. On days that I haven't had much sleep, or I'm a little more stressed, or I'm not distracted, I'm just sitting around, or when I'm much more aware of my pain and it bothers me more. On other days, it's the same tingling that's there, but it just doesn't bother me. So I think it's, as much as you don't want to say deal with it, live with it, but you on some levels, you have to learn to live with it. I kind of think of it as my partner. It's this white static that's in the background, and it can either be ramped up because I'm of the reasons I told you, or it's just there and it's not bothering me. Doesn't mean it hurts any less. It's just not bothering me as much.
Thank you.
No, I'm glad you brought that up, because I think that can lead you down a dangerous road if you're really just trying to combine everything to get yourself to a pain-free point. I mean, if you can do it safely, that's great, but sometimes just learning to live with it, using mind body meditation, all these things.
Well, thank you both so much. Thanks for being here with us. Thanks for good information, and hopefully a lot for people to apply moving forward and dealing with these lives and these sometimes challenging bodies that we have.
Great. Well, thanks so much, Chris. Thanks, Mike. Thanks, Kathy, for reaching out to us. I'm actually from Ithaca, and I go back. I live in New York during the week, so it's nice to connect with some upstate folks with spinal cord injuries. Some point I'm going to be up there, so hopefully can join you guys. So.
Well, Trevor, I have a quad rugby team, so if you're looking to,
I got to take care of my shoulders, Chris. I'm sorry.
Upper limb preservation.
I'm too old. I'm too old for that.
my shoulders hear you, and my shoulders wish they were your
Yeah.
shoulders.
Plus, my injury happened from playing regular rugby. So I think if anything has the word rugby, my wife will divorce me.
Yeah,
Dr. Hudson, you practice out of Ithaca?
Pardon me?
You practice out of Ithaca?
I don't know. I live there, on the weekends. I mean, I grew up in the area, and but I've been working in New Jersey for 27 years. So
I'm in Binghamton, that's why I asked. So.
Oh, okay. Yeah, another Southern Tier person. Yeah, and I'm, even though I am a physician, I'm, I'm research based. I really don't practice clinically. So, yeah, I mean, it's challenging for people to find good spinal cord injury physicians. So, it's always good to connect with somebody. Once you find somebody, spread the word.
Thanks so much.
Thanks, everyone. Thanks for your time and your questions.